order that you tried your equipment for introductions. So as you know, I'm Linda Cole. I'm a nurse midwife and have been for 23 years. And almost all of that time has been spent in a birth center practice in Knoxville, Tennessee. And I had been a labor and delivery nurse for 8 years prior to that, prior to midwifery school. I did not go to Frontier. I went to a program that's now closed in South Carolina. And I had already had two children at home and worked in a small community hospital as a labor and delivery nurse, and then worked for four years in a large tertiary high-risk OB setting. And so I had experienced the entire spectrum of home birth to high risk, and I knew there was this place called a freestanding birth center where I felt like I best belonged. And so I was lucky to find a position right out of school at a birth center that sadly enough just closed in December of last year. Lots of reasons behind that. But the good news is that Baby and Company came in. Baby and Company is a sort of a franchise model. I think they have maybe 7 or 8 birth centers now. And they came in and started a birth center in Knoxville and hired most of the staff from the birth center where I was. So good news is there's still a birth center in Knoxville. So anyway, I just finished writing a textbook, the very first textbook on the freestanding birth center model that'll be available right before American College of Nurse Midwives annual meeting in May. So I'm excited that that's done. And I have two sons. They're ages 27 and 29. And that's me in a nutshell. Pam.
I can't with your introduction.
You can't what?
I can't with your introduction. Now I'm echoing. Is there a way to stop that?
If the rest of us eat, it might help. Let's try that.
Is that better? Yeah, that's better. That's what it was. So all they did is just mute theirs. So I'm from Minneapolis, and I'm a family nurse practitioner. And I'm a Frontier grad from 2009, and it's great to be back. I work currently, I started out initially kind of doing some urgent care, some convenient care things, and decided I kind of like to be one of those that likes to know everything about one thing rather than a little bit about lots of things. So I've specialized into pain care, and I've been in there ever since. Kind of interesting because I did this presentation mostly on some of the problems that I see in the clinic, and was getting a little frustrated because I felt like all I do is do medication management. And of course you can imagine with everything that goes along with it, you feel like you're police most of the day instead of really helping. And so I'd actually had given notice that I was going to go to a different practice inpatient, so I didn't have to write the scripts, but yet I could stay in pain, which kind of awoke my docs up to the fact that maybe we need to look at some other alternatives. And this week they actually asked me to stay with them and start a complementary medicine clinic. So my dream has kind of come true. And I said, well, that's coincidence because I've literally just finished doing this big presentation on everything. So it's really cool.
So that's the exciting news you alluded to in your email.
Yes, exactly. Yeah.
Well, congratulations. That is very, very exciting.
And I just lost my father, and that's obviously why I'm presenting late. And he was a traditional Chinese acupuncturist.
Really?
So I'm really excited to be incorporating some of the things that he believed in. So.
Oh, that's so lovely, Pam. It's so lovely. Yeah. Mm.
So that's kind of my story in a nutshell. I do have 3 children that are grown. I've got 1 grandbaby and a second on the way. And
wonderful.
And even when they changed my position, they changed me down to 4 days a week. Didn't change anything else, so I'll accept that, and I'll have more time to spend with my family. So it's all good.
Great. Can't wait to hear your presentation.
Thanks.
All right, Elizabeth. You'll need to unmute yourself.
There we go. I got it. So
Mhm.
now I get to follow both of you. So I'm feeling a little intimidated. So I'm a midwifery student. I have 4 kids. I came to midwifery when I was expecting my first child, who is now almost 19. But it took me quite a while to get from my interest in midwifery to where I am now. Obviously. I have been, since I graduated from nursing school in 2013, I began as a birth assistant for the practice that was at the home birth of my 2nd, 3rd, and 4th children. So they are definitely like family to me. And after a year, when I first started being a birth assistant, I decided there's no way I could be a midwife. That it was so overwhelming and such a huge responsibility. And I was a little intimidated, I guess, by the process. And then at a point of a year, I was leaving a home birth and I looked to the midwife I was with and I said, you know what, I can do this. And I, told her that I had been doubting it. And she said, that's why you'll be a good midwife. Because if you don't recognize the enormity of what we're doing, then there is no way you would ever be safe provider. And she said the fact that I recognized it was a good thing, even though for me that year was pretty like a big, I doubted myself significantly over that year. But now I'm here and I'm doing part of my clinical with that practice. And my presentation is actually about joining that practice. So, I guess I've known them for 17 years now. So I work now in the OR, I guess, is my job. Mostly do orthopedic surgery and almost no GYN. And I guess that's about it.
All right. And Elizabeth, I was with you at Clinical Bound, wasn't I?
Yes, you were.
Are you guys hearing the echo? Do I have an echo?
No.
Okay, good. So what state do you live in?
Me? I'm in New Jersey.
New Jersey, okay.
And I will say in my county, 28% of births in 2014 were attended by midwives. So we're a very midwife-friendly county.
Very good.
Yeah.
So is anybody hearing my echo besides me? I'm going to move over and hardwire in. I don't think I'll lose you guys. Let's see. Hold on. Okay, does that sound better? Great, okay. Hold on a second. Okay, all right. So Darcy, go ahead and introduce yourself if you would.
Hi, I'm Darcy. My background is mostly in pediatric nursing. I did that for about 7 years. I did traveling and mostly float pool throughout the medical floors and ICUs. Now I've been in labor and delivery, high risk labor and delivery for about 1.5 years now. And I caught the birth bug when on my very first clinical in nursing school, I got a special opportunity to go to labor and delivery instead of one of the other floors, and I was hooked since. And so it took me a long time to get into labor and delivery and to decide that I wanted to go to midwifery school, but I'm so glad I did.
Great, and so are we. All right. So, all right, I guess we're ready to start the presentations. And again, just make sure that you are thinking as your colleagues present about what you might like to hear more about or have questions about. So Pam, whenever you're ready, you go ahead and screen share and just begin.
All right. Not sure how I got that off before. Is that okay?
It's not in full screen.
Yeah, I'm trying to figure out how I did that before. Oh, here we go. There we go. There we go. My little introduction there. I tried not to put too many of them in there because they can be a little annoying. Anyway, I am proposing to actually start a clinic, just a very small clinic that can use this integrative model, and that is how I started it. I wish I would have known in advance I was actually going to be joining a practice. I would have redone it, but anyway, we'll go with this for now. But it's basically going to be addressing the needs of the patients with chronic pain and also chronic illness, because a lot of the illnesses, that I see with my patients, include the pain aspect as well, using the multimodal approach. So I'm calling it North Metro. That's the area where I practice in now, and kind of the area, the demographics that I'll share. Be a privately owned clinic, and again, practicing in a safe environment, friendly environment, and as much as possible utilizing the non-opioid aspect of it. So I'm from Minneapolis. Can you see my mouse if I draw in here? Everybody see my mouse? Okay.
I don't see. Oh, yes, I do. Yes.
Okay. So this is the state of Minnesota, and we're right down in this area here, around the Minneapolis area, and the population of the whole state obviously is 5.4 million, and 60% of those residents live in this area that I'm circling here, right around the Minneapolis-St. Paul. They call it Twin Cities, Minneapolis-St. Paul, just divided by the river. Hennepin County is the center of the population, and the median age is 36.9. Interesting enough, 9% of the population is uninsured. We have a huge program here. They call it MNsure, which has been quite a challenge with patients. 86.9% American, small African American, small Asian, kind of a mix. We do have some big Native American reservations. I was kind of surprised that the percentage didn't increase over the 1.1%, but that's what the most recent statistics. And our unemployment rate is actually quite low. Now, these are the 3 counties that surround the Minneapolis-St. Paul area that I did most of my work on, because obviously that's where most of the population is. And the community needs of being opioid and drug abuse, alcohol abuse, and obesity. So drug abuse in the Minneapolis area obviously has been increasing as it has been elsewhere. And I thought the statistics were quite alarming, with us between the 2012 and 14, 719 deaths in these 3 counties due to opioid drug abuse. Now, when they talk about opioids, they're also including heroin as the opioid. So prescription and also, but this specific one here is just the prescription abuse. 20% of the Americans received health insurance for public programs. So that's kind of what leads into the problem of these programs don't really recognize they will pay for the prescriptions, they'll pay for the opioids, they'll pay for, narcotics, such, but they don't pay for the alternative options, such as your massage and your acupuncture and, some of those things that we know which would be helpful. And these are the population that can't afford it on their own. So with the drug abuse problem, the research does show that there's just a direct correlation with patients that have been treated for chronic pain. Excuse me, for chronic pain. Now the key is here, this isn't acute pain. The new CDC guidelines are stating more that they want opioids used mostly just for the acute pain phase, and then they're off it. But it used to be, when the pain became the such important vital sign, that we paid more attention to it, and thus a lot of patients were started on the opioids and just aren't getting off it. But it does, just the fact that they're on it for chronic pain puts them at a risk for misuse and even diversion, which I see on a daily basis in where I'm working now. There's also an issue with those that are using the narcotics and ending up using heroin. And a lot of times when I do urine drug screens in my clinic, I will find that these patients are negative for their prescribed, but they will be positive for another illegal drug. So obviously they're selling and changing anyway. Pretty astounding, 2 million Americans are dependent on prescription opioids in 2014. And 50% of the opioid overdose deaths involve the prescription opioids, which I think really opens your eyes to the problem. 2015, 33,000 individuals, or 33,000 individuals died because of it. And on an average day, 91 Americans died from it. So alcohol abuse, we do, again, rank a little higher than the average. Right within the hospital here, the Hennepin County is like the right downtown area, which is a little bit higher. And binge drinking is defined as 4 or more per woman and 5 drinks for the men on one occasion the past 30 days. I thought that was interesting. Heavy drinking is 1 drink for women or 2 drinks for men on a daily basis. So I guess to me that's almost more of a, it doesn't sound like heavy drinking, but I think they're using it in the context of it's going on at a very regular basis rather than just you're sitting down and drinking compared to the binge drinking. As we all know, it puts you at increased risk from multiple comorbidities and other problems. And the combination of the overdose and the combination of the opioids and the benzos, that's the new thing that is concerning and that the CDC is actually addressing, where we're not supposed to be writing any prescriptions. Well, obviously our patients are told they cannot drink, and we do check for alcohol in our urines with their narcotics, but then also you put together the benzos, and it's a huge problem. So definitely a direct correlation also between pain and alcohol. So we need to find some other ways to treat the alcohol. Obesity is quite huge. We do have access to a lot of, parks and things like that. We're actually known as one of the biggest cities, the most biking friendly cities. We have bike paths all over. So, we aren't, we have access to it. So there's really no use for them not getting out and using it. But 25 to 30% of us are obese. And also the association here again with the pain is we know that the obesity increases the back pain and again the disability and multiple comorbidities as well. So as we know, the APRN's access to the rural and local socioeconomic communities has been very helpful. There are underserved communities right within the Minneapolis area, right down in the heart of the city, where there's a lot of poverty. We actually have quite a homeless problem as well. And we are reimbursed. Our state here, most of them are approximately 15% lower than the medical doctors. And the research shows that we provide excellent care, often better than the physicians, which I believe is true. And I hear it on a daily basis almost when I hear patients that come in. We were trained as nurses. We care for our patients in kind of a different way. I think more of I don't know. I tend to think we're better listeners and look at the whole picture, a little more critical thinking sometimes, but that's just my opinion. We do have care that results in high quality and very effective care. And it looks like I duplicated that slide. I must have thought that was very important for some reason. And there's lots of different associations. Like I said, that I specialize mostly in the pain management, and therefore I am a member of the association, the American Association of Pain Management Nursing. And I think that's unique that, there's so many different associations that you can join to become even more specialized in the area that you practice. So the business structure that I decided to go with was just a very small clinic, starting out with myself on a limited liability corporation. And some of the advantages are, obviously you file your own taxes. It's easier to start because it is a smaller business. We are protected by the LLC. And sometimes the LLCs are looked upon more favorably for the lenders, some of the places that we have to go to give us our supplies and such. Disadvantages may be the self-employment tax, and of course another disadvantage is, we don't have a lot of the perks of having our provided vacation and PTO and things like that when you're working for yourself. There is limited growth potential because you're not going to have the access to really any other investors. So my goal is to start it as a small practice and increase it at a later date as things grow. Budget review here is the second year to add an additional nurse practitioner. Initially using the one full-time receptionist and having them be knowledgeable and able to do the billing and insurance for the first year. And the second year add additional. Wages and salaries and everything are based on Minnesota averages that I found. Clinic will be open 5 days a week, and I'm approximating that the provider will see 80 patients a week, with 15 of those being new patients, and then the additional visits as follow-ups. And again, the reimbursements are reduced by approximately 15% based on the Medicare and Medicaid payment schedule. We really don't do any labs and therapies and such. We do the urine drug screens, but they are sent out to outside labs. So I didn't include anything in that for the budget. So I end up coming up with, for the first year revenue of this amount, you have your personnel expenses, operating expenses, the margin of error, and actually showing a small net income, which kind of surprised me for the first year. And then going into year 2, the revenue doubles with the addition of the second nurse practitioner, the additional staff members, and showing a much greater, obviously, because we don't have all those startup costs figured into that. So in conclusion, this is the clinic that I'm designing, which actually now I'm actually able to do in real life to some extent. And I really am a believer of adding some of these alternative therapies. I'm just in hopes that over the next few years that insurance companies will start recognizing those things. And I think the outcomes will be just great for the patients. So my references.
Thank you, Pam.
Mm-hmm.
All right, Elizabeth.
Okay, hold on here. Okay, so I am Elizabeth Clarkson, and this is my Disruptive Innovator presentation. So my concept is joining a practice. Midwifery Care Associates is a 25-year-old small private midwifery owned and run practice in Mercer County, New Jersey. Mercer County is in central New Jersey on the border of Pennsylvania. It is a diverse population of approximately 370,000. It includes the state capital of Trenton, and also the neighboring county includes a large Air Force base with a rotating population of approximately 44,000. The community needs, Mercer County includes multiple very affluent communities, but also high poverty rates in Trenton of 24.5%. The low birth weight in Mercer County is higher than both the state and also nationally. The teen birth rate is 22 per 1,000 in Mercer County as opposed to New Jersey at 18.7. It is lower than the national rate, but it does stand out in New Jersey. The STI rate in Mercer County is also very high, with 465 per 100,000, which is significantly higher again than the rate in the state. And the improved access to midwifery care could have a positive impact on these rates and also the well-being of the community as a whole. So the mission statement for the practice is that it believes that every woman has the right to safe, sensitive health care provided with respect for her individual wishes, cultural background, and her right to self-determination. We believe that our mission to promote family health and comprehensive health maintenance is best achieved by an interdisciplinary team approach. Student midwives and newly graduated midwives enhance our full range of care and are welcome members of our professional team. The business structure, it is a private practice. It's based on the midwifery model of care. Appointments last generally between 30 to 60 minutes, and a holistic approach is used to bring the latest in evidence-based care to women from menarche to menopause. The practice is owned by 3 midwives, with only 2 of whom are currently practicing. They do home and hospital birth and have rights at the local hospital that is actually baby friendly, which is nice. It also participates in an off-site adolescent clinic and provides full scope midwifery care. So my plan would be to join the successful 2-midwife practice and to bring the energy and drive of a new certified nurse midwife to their successful practice. And along with that, the latest research so they can really stay up to date on what's happening in research today, and also be able to increase the profitability, because with such a small practice, adding a 3rd midwife will allow them to raise their cap of patients each month and be able to take more clients. So because it is a small practice, the numbers might seem small, but I would be able to increase the number of births per year by 28, and the GYN visits per year to 144, and 308 prenatal visits. These are all based on the current practice office data, and I will say that they, at this point, only do 2 days in office per week. The expenses, salary and wages of the midwife, and also the office manager, who is also a phlebotomist, and then the birth assistants is $86,000, which might appear low, but again, as a home birth and hospital birth midwife, if you're only doing 1 office day a week per midwife, it's definitely a lifestyle choice as well as a profession. The operating expenses are $36,000, making a total yearly expenses of $143,000. So the birth revenue, the global fee is what I base this on, and 95% of the clients are actually self-pay, and 5% are TRICARE. They changed it about 5 years ago to self-pay because they spent so much time and energy chasing down the insurance companies, and it really wasn't allowing their business to be successful. So they now make it where you have to pay for all your birth costs by 30 weeks, and then you get reimbursed by your insurance company. They are in network with TRICARE, which is the military insurance. And TRICARE actually pays their midwives the same reimbursement as physicians. Though in New Jersey, if it was Medicare, we would get 70%. So for the well woman visits, self-pay is $150 and TRICARE is $172 or $127. So in terms of profit and loss, the total income is $215,000 that I would bring, and the expenses $143,000, and actually the profit is $72,000, which definitely would make my addition to the practice a positive one. So in conclusion, joining an established midwifery practice will help to grow an already thriving small practice and will allow the patient-centered, evidence-based care to reach more families and help more women and infants. And those are my references.
All right, Elizabeth. Okay, Darcy, whenever you're ready.
All right. Okay. Mine is joining St. Mary's Apple Valley Midwifery Practice. The statement of proposal, I propose joining St. Mary's Apple Valley Midwifery Service in Apple Valley, California, serving women and families within the community to improve the infant mortality rate, decrease teen pregnancy rates, and increase early entry to prenatal care. Apple Valley is located in San Bernardino County, California. It's in the high desert above the mountains in San Bernardino County. The practice serves the communities in the surrounding areas of Victorville, Hesperia, Adelanto, and other small cities and towns around the Inland Empire. The population of the area is 1 million, about 1.4 million. Poverty levels range between 14 and 26%. Adelanto has the highest at 26%. And St. Mary's has a satellite clinic in Adelanto. 37% of the population is Hispanic Latino, 46% is white Caucasian, and 8.4% are Black or African American. The community needs that I decided to go with were teen pregnancy, infant mortality, and prenatal early entry to prenatal care. So in the service area, there's 37.3 per 1,000 teen pregnancies. In California, it's 28.7. The U.S. is 31.3, and the healthy the 2020 target goal was 36.2. So my service area has a higher teen pregnancy rate than it should be, and I hope to be able to provide comprehensive service to them for STD testing. This practice is Catholic, so we can't provide any kind of birth control, but we can refer to where they can get it. And providing community education for them. Infant mortality rate per 1,000. The service area was 6.6, California 5.3, the US is 6.9, and the target is 6. So we're a little above. Early entry to care and continuity of care is important for helping to reduce the infant mortality rate. Studies show that the earlier prenatal care is started, the better the infant comes. In our area, 82% of women do start their prenatal care in the first trimester. In California, it's 81%, and the US is 76%. The target is 78%. I still chose this one because in our service area, we're not the only providers, and we do get a lot of patients that come in late to care. How to help with these issues is to provide whole person care, community education, continuity of care, and make it family centered. We already have community education that goes out and helps educate the community about what we have, what we can provide for the community. And it's also whole person. We offer counseling, and dental hygienists come in a couple of times a week for that kind of thing. St. Mary's Apple Valley is a nonprofit organization. It is under the St. Joseph umbrella. It's a charitable organization, and it's also a religious organization. They don't pay federal taxes. They have to be governed by a board of governors. There's other stipulations for being nonprofits. They can also receive grants and donations. Utilization. So there's already 5 CNMs and 1 FNP in the practice. They do 25 to 30 births per month, about 350 per year. OB and GYN visits are about 2,500 visits per year between all of the providers. This comes from the office data that I was given. And I lost my train of thought. I apologize. They were looking for 2 CNMs to replace one that's retiring and one that left. Total expenses comes out to $227,033. Of that, operating expenses account for $67,454, and then my salary as well as portion of the receptionist and MA salaries. We would split it 7 ways total, and there are 2 receptionists and 3 MAs that we have to account for. Revenue insurance, mostly Medi-Cal, which is the Medicaid of California. We work with a lot of low-income moms, and because we do a lot of community outreach, we're able to pull these women who need help in that don't necessarily have it anywhere else. Commercial insurance, like PPO plans, account for 7%, and Medicare, mostly TRICARE, is 3%. So for births, the revenue per year would be $197,857, and each of those for the Medi-Cal reimbursement is $1,390. For commercial, it's almost double that, $2,400. And then other charges that we can account for are specimen collections, such as the Group E strips and PAPs. Profit loss, revenue would be $221,24, $238,384. There would be a loss of $18,259. Am I missing something? Oh, it's not going the right way. Okay. So there would be a loss of $18,259. This addressing the issue of it being a loss. There's going to be a midwife retiring, so I can help to ease the transition from her leaving to me going, and that can take care of some of that first year loss. Donations and grants are a possibility as well. My clinic didn't give me any information, any financial information, so I had to find all of that on my own through salary.com and searches on Google. And then also I can increase patient visits per year to help address those issues. In conclusion, the inclusion of an additional CNM to the St. Mary's Apple Valley midwifery practice would benefit the practice by streamlining retirement of the other midwives, increase community access to quality midwifery care, educational and support services to help improve access to early prenatal care, and decrease infant mortality and teen pregnancy rates. And those are my references.
Thank you, Darcy. All right, so I would like to just open it up to questions and things that you all would like to hear more about, and then I have some questions and might steer the conversation in a couple different directions. But I want to open it up for you all first.
I had a question for Elizabeth. I'm just curious. Why do you feel that the STI rates are increasing like they are?
In my county,
Yeah.
or I think honestly, I think one of the issues that we've had in Trenton is that all the maternity hospitals have moved out of Trenton. There used to be a hospital right in Trenton. It closed and it moved to a more affluent community the next town over, where you actually would have to drive to. And they've just been reducing access in Trenton, and in Trenton is where we have the largest increase in STI rates in Mercer County.
Interesting.
It's actually a really big problem with access to care going on in Trenton right now.
Is there a health department in the county that treats STIs?
There is the health department. I just think a lot of people don't have ways to get there. I mean, Trenton is not a tiny city, and there's people don't have cars, and it's a lot of unemployment, and it's kind of the opposite of an ideal situation that goes on in Trenton at this point. And it's just getting worse and worse. It used to actually be a really successful city with, right now, the only successful things going on in Trenton are the fact that politicians come because it's the state capital. But besides the restaurants that are like right close to the capital, there's really just poverty and crime and gangs. So, which is weird because Princeton is also in Mercer County, and Princeton is one of the wealthiest towns in New Jersey. So, very diverse. Well, I have a question since my microphone's on. So Pam, what I was curious about with your presentation, because you're talking about integrative treatments and complementary treatments, and I'm just curious in terms of insurance, what have you found in terms of what is it that you want to offer that won't be covered, and what you think you might be able to do to solve that?
Yeah. One of the things that's available. We're echoing again. Am I echoing? Oh, there we go. One of the things that we want to offer is acupuncture. Now, I currently do something called dry needling. I'm an integrative dry needling. I'm certified in that, which is kind of like trigger points, but we use a acupuncture needle. I can bill that, or I can charge that out underneath a trigger point, except it would be minus the steroid. So that's really similar. But when it comes to the actual, the traditional Chinese acupuncture, there are very few insurances that will pay for that. And I do see that is changing, because as I said, my dad he practiced 50 years in the acupuncture industry, and it had started improving a little bit, but it's still a very small amount. Some of the other things that we're wanting to bring in are, we want to do massage, which I think we'll be able to. I don't know if we bring in like a physical therapist that would offer the myofascial type of release and then use that as a massage. But we're pretty certain that this division of our clinic might have to be mostly cash pay because of the reimbursement problem. So it'll be interesting. I'll talk to you in a year, and we'll let you know how it turns out.
Thanks.
I'm going to just chime in here, Pam. I find your work very interesting. I think most of us have someone in our family who has struggled with addiction of some sort or another. So I think your work is very important and meaningful, and I'm imagining very difficult at times. So I'm wondering about a couple of things. One is, besides, you did mention that drug screens that show up positive for heroin can then lead you to believe that diversion is happening. Are there other ways that you can detect diversion if drug screens aren't showing heroin? That's one question I have. And the other question is, your project is introducing a new way for patients to deal with their chronic pain. If these patients are already taking opiates, how difficult is it for them to move into a willingness to explore an alternative to that treatment?
Yeah, so getting into the diversion question that you had, there are things that we will even have to do because patients are really smart. If they want their meds and they're getting them and selling them on the street, they're smart enough to know that they will save just enough to take prior to their visits so that their urine drug screens are normal. The other thing is that we actually will see patients that will do what we call scraping. So they'll actually take some of their narcotics when they do their urine and scrape a little bit of it in, thinking that it's going to be showing what's normal, but they don't realize that when we test, we not only test for the med, but we test for the metabolite. So obviously that's another flag. We do temperature on the urine, and we've had people bring in other things. We've had people use lemonade. I mean, it's kind of sad. I mean, and that's why I knew I needed to just, I just see more of it coming that way. And I was just getting kind of burned out with the whole aspect because I don't feel like I'm really doing what I went to school for. I don't want to be the police. Let's see, what was your other question? Oh, how are we going to get those people? So truthfully, when a patient first comes to us, we present, this is your plan. And if they come to us, unfortunately, a lot of them on very, very high doses of narcotics from a primary care provider, they get them increased and then they panic and they're like, oh, you need to go to the pain clinic now. So when we design their initial plan of care, we tell them, we will not continue at these doses and we will write out a weaning schedule. It might be, 5% a month or whatever. And pretty much tell the patients, if you're not wanting to do that, then, we're not there's nothing that we can really do for you. But so we have it in writing. We make that pretty clear. I would say the majority of patients that are truly the pain patients that are there for the right reason and for the help are open to a lot of these ideas. It's just been the frustration that they can't afford it. And again, that's going to be a real struggle to try to get some of that coverage. I had done a little bit further of a plan in the other class that I'm in right now, and I was thinking of bringing in some of this, incorporating a couple of the schools. We actually have a school here that teaches chiropractic and traditional acupuncture, and we also have a very popular one that does massage and aromatherapy, whatever. And I was thinking of a way to maybe even incorporate initially some of the students to provide some services for our patients. Still have a lot to work through, so we'll see.
I'm guessing that there are folks who are working on the policy level in terms of reimbursement for some of these alternative therapies.
Absolutely. When I started doing some of the research on this, there's a lot of integrative societies there, and I think they're going to get there. And I think it's going to be sooner than later, especially now because the CDC is issuing these guidelines. We have to abide them too. And it's like, okay, well, you're not leaving a lot of options for these patients. So you guys need to look at, insurance companies need to look at what we can do for them. So in the long run, it's going to save them a lot of money. If you figure what they're paying for the meds that these patients are getting compared to what a treatment of acupuncture a week or something would be, it's just, we need some good lobbyists.
Yeah, save a lot of money and potentially save a lot of lives.
Oh, absolutely.
Yeah.
Yeah. I have one of the things that I run into is I'll have patients say, they'll overtake their meds, and I said, I'm sorry, this is part of your contract. You have to take them as directed. Well, I've taken these, 1 extras, that's not going to be a big deal, whatever. And when I share statistics with them, that this is, this can be the problem. That might be just this 1 extra pill, or, and kind of get it. They're just astounded. They have no clue. So a lot of it is education.
For sure.
So, yeah.
Thank you.
Mm-hmm.
Other questions?
I have one for Darcy.
Great.
It was interesting to me, your figure. So I guess I was astounded by the figure. You said it was $13.90 per delivery.
Yeah.
And she goes, oh my gosh. And does that include the prenatal and postnatal and everything?
That's the global fee, yes.
Oh.
So it also includes the delivery, Darcy?
It does. I was actually, in my research, I found that there's a lot of providers that don't want to take Medi-Cal because the reimbursements are so low.
Yeah, that's really low.
I know, and I was looking around, I looked at the fee schedule, I tried to make sure that I was getting the exact reimbursement, and that's what I found every time
Yeah.
Yeah, I was contrasting that figure with Elizabeth's figure, which was what, 7,000 something? I forget what it was, but
Yeah, it's 7,500 for self-pay.
and that's a global as well, right?
Mm-hmm. And that's for whether you have a home birth or a hospital birth. Regardless of where you deliver, that's what they are paid. But at the same time, and I didn't know how to really put it into my numbers, they do make, there are, let's put it this way, there are women in the area who, when you say it's $7,500 for exactly the birth that they envision, they write you a check that day. They give you $7,500. And then there's other people who come in and they can't. And so, there are times where we take like squash, and I didn't know how to put that into they have done barters with people who have farms where they'll say, we'll give you X number of bushels, but you can't, they have a long history in the community. So there's definitely, they do bend it, but they say one of the reasons they make the $7,500 is because the women who can easily pay that and happily pay that will kind of subsidize some of the people who, and the numbers change every year. So I really couldn't add that into my figures because we never know going into each year how many people are going to come saying, I really want a home birth, but, we can't afford it. Will you work with me? And they can, because there are enough women who are in Princeton and Hopewell who have already written that check, so, but TRICARE, I was actually amazed that the military pays CNMs. We're the only nurse practitioners that they pay fully to. When you look up physician, it's, all doctors and then certified nurse midwives. And then in the other non-physician, it's everybody. It's basically everybody that wasn't listed in the physician. So that was nice to see. But I also like the fact that they do TRICARE because there are so many families who could really use the kind of care and attention that the midwives give to them. And, they don't have roots, they're moving, so that's one of the things that I really do like about that practice is they do, support the military in the area.
I've had other students self-pay idea in other presentations, and I think it's something we may see more of, actually. But sometimes what is the case is that if they have insurance, that they're going to have a pretty big out-of-pocket expense anyway. And if they're getting the birth that they want, if they end up with an out-of-hospital birth with, as we know from lots of data now, have much lower possibilities of major complications. Then, you know, if they were in the hospital, they might end up with a much larger bill than $7,500 with their copay and all of that. So something to think about. The other thing with the self-pay model that I like is that with global OB, as you know, you don't get paid until after the birth. So you've got, you know, this 8-month period, 9-month period where you're not getting paid. And with the self-pay model, you've got that steady stream of cash coming in, which sustains the practice. I was interested that both your proposal, Elizabeth, and yours, Darcy, involved pretty low visit numbers per year. And so, and Elizabeth, you said you would be working 1 day a week in the office?
Well, what they do is they, right now, with 2 midwives, they have office hours 2 days a week. In the past, they had 3 midwives, and they did 2 office days and then 1 evening. So it was really only 2.5 office days a week. And if you have 3 midwives, you know, you'll only spend 1 day in the office. But because it is a home birth practice, you're on call, you're going to be doing home visits that day. So everyone who has a home birth gets a home visit at 35 weeks. And then you go to their house for the birth, and that would be a call day. You'd be the one who would go to the home for the birth. And then they get a 48-hour home visit again. So those things all happen when you're on call, but not in the office. So, and you're, you know, the way they have it with 3 midwives, it's 10 days first call, 10 days backup, and 10 days completely off. Not in that order, but throughout a month, you know. So it's a really nice schedule. It's just not as much money, and it's kind of a trade-off about what your focus is and what it is, you know, you are able to, you know, balance, I guess.
It is a trade-off.
It is a trade-off.
Quality of life issue for midwives. And if you can figure out how that's going to work, then that's great. Yeah. Good. Okay.
I have to admit that if I were to add myself to that practice, I would have to stay 1 day a week in the OR per diem to be able to pay off, you know, student loans and everything. So definitely a trade-off.
Yeah.
As for my numbers, the clinic there's 7 providers. There's 6 at this point, but there will be 7. And each provider they're in the office 2 to 3 days a week. And between 1 or 2 providers, there's usually only about 20 patients per day. So we're seeing smaller numbers, and then we're only working 2 to 3 days a week, and then our call is 1 24-hour a week. So it seems to be my clinical site, so it's been a very nice steady pace.
Mm-hmm. Yeah.
The patients get a lot of individual attention.
Sounds like it. So talk to me a little bit about your experiences with this assignment. Was it difficult for you to gather information that you needed? Were there some people that were helpful to you, such as office managers or colleagues, or were there things that surprised you that you found out? Were the providers that you talked to, whether they were preceptors or colleagues, were they aware of the revenue, or you, Elizabeth, yourself? Were folks aware of the revenue that they were bringing in to practices?
I have to say, I learned a lot. I've known this practice for a long time. The midwife who started it and was in charge of all of the finances retired 2 years ago. And she still is now part owner, but I was speaking with the midwife who runs everything now, and she joked that people ask her all the time, how much is, Louise involved? And she said to me, honestly, all she does is the footprint papers, which is she writes calligraphy on the birth announcement footprints, and like that's the extent. And the midwife now said she never imagined that she would be doing what she's doing. And she's doing it really well, but I definitely, you hear the malpractice is high. Well, she pays $38,000 a year for, 2 midwives. And that's how I look at that and think, gosh, well, if I wanted to be on my own, there's no way that I could start a business as an independent practitioner and have to pay that much in malpractice. So it was definitely very eye-opening, and I learned a lot about not only the practice that I've known, but also just the business in general of midwifery.
I was lucky because when it came to trying to figure out fees, I actually talked to our biller, and she basically provided me with, and that was interesting to me too, because it's difficult to find. It was even difficult to find I still never found what I think are probably the accurate reimbursement from some of the insurances. I just kind of gathered it from what we looked at the clinic. That was difficult. I don't know if anybody had any better, links or whatever for that part of it, but
Were
it was
you actually able to find out what you yourself generated in revenue for a 1 year time period or anything like that?
I kind of figured it out on my own because I have a template. I see 22 patients a day, and I usually bill out, between a 313 and a 314. And so I used that kind of, well, it's kind of similar. The plan I made is actually less patients than I truthfully see. So yes, it was eye-opening to me, thinking maybe I should ask for a raise, but no. Like I said, they've given me this great opportunity. So, but it was interesting to see that.
Darcy, what about your experience?
I thought it was really interesting as well to look at what revenue I could bring in for the practice, and the difference between my rates that I have and my actual revenue is a lot. So I can see how big of a hit they take from taking the Medi-Cal, but that's their passion, and that's a good thing. Those are the people that need us. As far as finding my facts and everything, I had a hard time getting much information from the office, so I looked up a lot of my stuff. But I was shocked at how low the reimbursement was for our Medicaid here. It's shameful.
For sure.
It really is.
All right. Well, some great discussion. Any other questions that you all have, or comments or anything?
No, I think it was wonderful learning opportunity. A lot of work, but it was worth it.
It is a lot of work, for sure. And we've revised the spreadsheets to try to populate some things in there so that you don't have to go looking in such depth, like, the equipment sheet and whatnot didn't used to be there. You used to have to find out how much a exam room table costs and how much this costs, but that's not a good use of your time. And I think they can be improved still, but definitely some improvements have been made. So anyway, thank you all for your time this morning. Very interesting presentations, and I appreciate it.
Very much.
Good luck.
Thank you so much.
You bet. Good luck with the rest of the turnaround.
Thank you.
Okay. Bye-bye.
Bye.
Bye.